Good morning, everybody, and thanks so much for holding out for us. Sorry we're starting a little bit late this morning. My name is Sarah Wheaton. I'm the Senior Health Policy Reporter here at Politico, and I really appreciate you joining us today for this closing event for our series, Politico's Telescope, the New AIDS Epidemic. So thanks to you, thanks to our partners, Gilead, who are making this virtual event possible. And yep, we had some technical problems this morning. I hope you took the time to get an extra cup of coffee because we're in for a really lively conversation. And, you know, for the people who have been dealing with the HIV epidemic for decades, this, kind of resilience and going with the flow is just par for the course. And I have really been enjoying learning about this topic over the past year about doing this series. And before I go on much further, let's watch a video where we explain a little bit more about the Telescope, the New AIDS Epidemic series. A year ago, we launched Politico Telescope, the New AIDS Epidemic. Our mission? To look at what's changed in the fight against HIV since the virus first erupted into the public consciousness nearly 40 years ago. Yes. We found some major strides. People are living into old age on treatment. The idea of U equals U, undetectable equals untransmissible, means those receiving consistent treatment for HIV don't have to worry about infecting partners. And while there's still no vaccine or cure, it turns out that antiviral pills, initially meant to treat HIV, can prevent infection too. But a lot hasn't changed. HIV patients still face stigma, notably from their own doctors. While PrEP has revolutionized life for gay men, attitudes about sexuality in women can lead to late diagnosis and missed opportunities for prevention. Governments still find it easy to ignore vulnerable and marginalized groups like drug users or migrants. And we discovered that hard-won reductions in HIV transmission can quickly be reversed if we don't keep up our efforts. Of course, there's an enormous thing that's changed in the years since we started this project: the coronavirus pandemic. Many of the world's top scientists are drawing on decades of knowledge from the fight against HIV to take on the coronavirus. That means all of us are set to benefit from AIDS research. But there's one lesson from HIV that some places around the world insist on relearning the hard way. When it comes to fighting threats to public health, difficult choices, both by political leaders and regular people, are just as important as science and medicine. And as with any Politico event, even our virtual events, we love to have the audience be involved. This is your opportunity to ask questions, both for our one-on-one interview and for the panel. So I really encourage you to take the moment now to go to Slido where you can ask questions, and we're going to do a little poll to make sure that everything is working and to also kind of set the tone for the discussion. So please, if you haven't already, go to sly.do.com from your computer or phone and use the hashtag PoliticoTelescopeAIDS. And you can use that to ask your questions. I would urge you to ask them kind of as soon as things get started, because if you wait until the end, then you'll miss your chance to ask. And I am much more likely to take questions where people say who they are or what organization they represent. So let's go ahead and put up the Slido poll to give people a chance to weigh in here. So the question is, what is the biggest obstacle to improving HIV prevention and treatment? You have several choices here: drug prices, political indifference, the COVID-19 pandemic, lack of funding, or the unfinished search for a cure or vaccine. Okay, well, so far, people are not indifferent about their indictment of political indifference. I'm going to go ahead and move along since we are starting a little bit late, but please feel free to keep weighing in to the poll. And so I am, and I'll also encourage you to tweet using the the hashtag Politico Telescope AIDS. And if you add us at Events Politico, then we may well retweet you. And so now, without further ado, I'd like to hand over to Neil Mulcock, who's the Vice President for International Government Affairs and Policy with Gilead, our partner here. Neil, over to you.
Thank you very much, Jane. Just checking you can hear me.
We can, yes, thank you.
Great. Well, welcome everyone. It's a pleasure to be here this morning and to have the opportunity to talk with you all. This is a very timely conference or virtual conference that we're having as we approach the end of the HIV Telescope series. This event provides us with an opportunity to reflect on what we've learned over the past 12 months in this partnership. The series has provided us with a platform to consider and celebrate the progress made in fighting against HIV in Europe, but also to highlight the ongoing challenges that people living with HIV still encounter. We at Gilead are very proud to contribute to this event. Telescope has come at a very pivotal moment this year as we enter the last decade leading to 2030, the deadline set by the United Nations for countries to achieve the third Sustainable Development Goal, namely to end the AIDS epidemic. But 2020, as we all know, I think will be remembered for a very different reason. The outbreak of COVID-19 has wreaked havoc and cost over 1 million lives worldwide and has put our economies and healthcare systems under enormous strain. Among the many lessons we can learn from the outbreak of COVID-19, one of them is the importance of health preparedness and the need to continue to invest to ensure governments remain on top of viruses and infectious diseases. In this context, we must be careful to ensure that we don't jeopardize the progress that we have made in tackling the HIV virus. The COVID-19 crisis offers us an opportunity to reflect on how far we have come in our fight against HIV and the importance of continuously investing in research and acting to achieve the United Nations Development Goals, which can be similarly applicable to fight other viruses like COVID-19. I'm very pleased to see that we have such a diverse panel of speakers today, all with a strong expertise in HIV, and I'm keen to hear their views on the best way we can win the fight against HIV epidemic and ensure that the EU and member states remain focused on the remaining challenges of tackling HIV. For over 30 years, we at Gilead Sciences have been striving to transform and simplify the care for people living with HIV, but also working on prevention of new cases. This mission is still being pursued with an inclusive approach, partnering with a wide range of stakeholders, all sharing the same goal to win the fight against HIV. The scientific advances over the last 30 years have been unprecedented. And if you look at where we are now, we cannot ignore the role that innovation has played in fighting viruses. But I would like to emphasize that the fight against HIV is not over, and there is no time for complacency. In fact, I'd like to highlight 3 outstanding challenges which I believe the EU and the member states should address. The first one is aging and quality of life. People with HIV can now have a near normal life expectancy. However, they have higher risks of coexisting medical conditions than the general population. The ECDC has recently warned that we are seeing a rise in the proportion of diagnosis of HIV among older age groups, namely those who are 50 or older. They represented 14% of the population with HIV in 2009, and 9 years later, in 2018, they represent 20% of the population. The new challenge is to be able to address long-term health, well-being, and the quality of life for those who are living with HIV. The second challenge I'd like to propose is that of addressing stigma and discrimination. Too often, people living with HIV or from groups of higher risk of HIV infection are stigmatized, which discourages them from seeking and accessing the support they need. These 2 challenges can only be addressed if there is renewed political commitment to sustain the scientific progress and innovation in HIV, raising ambition to go beyond viral suppression. We need new policy approaches to address the long-term needs of people living with HIV and to tackle HIV-related stigma and discrimination. Finally, we need to work together to narrow the gap between Western and Eastern Europe. There are stark differences in the progress between Western and Eastern Europe countries in terms of controlling HIV epidemic. In general, Western European countries are on a path to meet the UNAIDS 90-90-90 targets. Although according to UNAIDS, as of 2017, only 2 countries in Europe, Denmark and Sweden, have actually met their targets. Additionally, important challenges remain, such as limiting the number of people being diagnosed with HIV only at an advanced stage of the infection, late diagnosis. According to estimates from 2017 from the EU EEA, almost every second HIV diagnosis has happened at a late stage. This means diagnosis several years after infection. We should all be troubled with the fact that the average time between being infected and diagnosed with HIV is still nearly 4 years. The Eastern European region is characterized by significant variations in progress achieved to date, and it has to go much further before it reaches the 90-90-90 targets. In addition to these, the issues of stigma and discrimination are widespread. And we cannot successfully talk about ending the HIV epidemic unless we make significant progress in addressing these challenges in Eastern Europe and adopting a European action plan to support all EU member states in achieving the Sustainable Development Goal by 2030. As was mentioned by the President of the European Commission's State of the Union speech in September, now is the time to discuss a strong European health union. As representatives of the life science sector, we are open to discussing where we can play a part in improving the health of the citizens of the European Union. Among the key policy strategies with the potential to pave the way towards a European health union is the upcoming European Commission's Pharmaceutical strategy for Europe. We at Gilead believe the strategy should recognise and encourage innovation as a strong asset for the EU to enhance its ability to be fully prepared to tackle any future health threats, but also to accelerate the elimination of existing viruses such as HIV. Ultimately, there is only one way to put an end to HIV, and that is by working together with all of us who are participating in this meeting and beyond. It is only by acting together can we get to 0 new infections, 0 discrimination, and 0 AIDS-related deaths globally. Thank you.
Thank you, Neil. And now I'd like to welcome Shannon Hayter. She's the Deputy Director at UNAIDS, and she has kindly agreed to fill in for Winnie Byanyima, who had a last-minute conflict. Shannon, thank you so much for joining us today.
Shannon, good morning. It's great to be here.
Thank you. Let me start by asking you what you would say to this poll that we have. Let me know if you need me to remind you of the options. But what would you say is the biggest obstacle to improving HIV prevention and treatment at this point?
Well, I would rarely go against the community response on any sort of HIV response, because I think we at UNAIDS know that communities are usually right. And I think I saw from the early response, I think you called it political indifference. I would call it sort of everything from missed opportunities for leadership and political commitment to, a growing vacuum among some constituencies. And I think that really feeds into where our missed opportunities for against the epidemic are. Because if there's one thing we've seen in our HIV response over the years is if there's a will, there's a way. Even before there was any technology, we could start to respond. And so things will always come back to political will. And that political will, I think, can never be taken for granted. Got to be driven by communities and people who care.
And can I just ask you to elaborate a little bit on you said a vacuum in certain constituencies. Can you tell me a little bit more of what you mean by that?
Sure. I know we'll have a chance to talk a little bit more, but I think, when we look at Europe, some of the leading responses in the world are from Europe in terms of countries that are responding well. We see the progress in their own countries paired with and nurturing global solidarity, and also perhaps feeding back through that global solidarity, motivating response. But we also see a mixed picture with a lot of inequalities. And I think even when we look at, let's say, the European Union as a bloc, I think we'd agree that health has maybe not gotten the same sort of solidarity and rallying as a bloc as perhaps some of the economic policies and things like that. We're certainly seeing the differentiation across countries in the COVID response. But I think we've even seen some of it in the HIV response. You know, it used to be through the European Union, there was a sort of a coordination platform for HIV, everything from the EU think tank to an EU civil society forum on HIV. And those have gone by the wayside since 2019. There have been political declarations over the years, everything from the 2004 Dublin Declaration on the Partnership to Fight HIV to even the 2016 UN political declaration commitments. Yet we haven't seen that Dublin Declaration updated in Europe, and we haven't seen a common European vision to take those 2016 commitments from the UN and make them personal to the EU. Even though certainly a handful of countries have done that themselves. So missed opportunities there, I think.
Mm-hmm. And one thing that is kind of just upending everything this year alone and maybe causing some rethinking of that sort of health solidarity is the coronavirus pandemic. What do we know at this point about how that's affecting the response to HIV?
Well, you know, a few things. I think it goes in a couple of different directions. Certainly at UNAIDS, we have been concerned since the early part of the COVID epidemic of what impact this could possibly have on global HIV progress to end AIDS. We projected that in Sub-Saharan Africa alone, if HIV treatment services, for example, were interrupted for 6 months, what would that do? And we projected it could add an extra 500,000 deaths from AIDS just this year alone, doubling death rates, taking us all back to 2008 mortality rates. So this possibility of losing a decade of progress in just 1 year. Fortunately, we haven't seen that. We haven't seen that not because that was a bad prediction, but because we've seen so much responsiveness from HIV communities around the world to put in place agile and flexible responses to make sure services aren't as interrupted as they would otherwise be. So we are certainly going to have some things to recover from COVID, but we're also seeing some innovations finally taken to scale, from telemedicine to multi-month dispensing of medications so you don't have to go back to clinics all the time, that hopefully if we keep those innovations and then really intensify our recovery, we might actually boost ourselves and get to even a better point on the way to 2025.
Well, that is a refreshing note of optimism. And are there some lessons from the early response to HIV that you think bear keeping in mind during this early response to the coronavirus pandemic?
Yeah, I think we're seeing several lessons and several patterns from the HIV response that are really critical to COVID. One, that the only truly effective HIV response is a human rights-based response. Two, that it's critically important that community leadership is part and parcel of the response. And I think three, really about access and expansion of access to interventions as they become available. On that first element, we saw at the beginning of the COVID response, and still some, similar to things we saw at the beginning of the HIV response, this idea that you have a trade-off somehow between a public health response when things are unknown and a human rights-based response. But the reality is we know there's no trade-off there. You can have an absolutely effective public health response, including restrictions, that is still human rights-based. Where restrictions are evidence-based, they're time-limited, they're subject to review, they make accommodations and supports for people who are most vulnerable so that they are not further marginalized. And in fact, we know from the HIV response, if you don't do those things, you push people into hiding and you never get to the end of your epidemic. So I think that's one thing. In terms of participation of community, and by communities, and community-led, I mean, nothing about us without us from the HIV response. Organizations led by people who are affected for people who are affected. Certainly in COVID, we've seen both for HIV continuity of services, but also for other functions, many of our HIV community organizations have been critical to providing innovative services for HIV, for contact tracing during this time. But in some of the other areas where we know it's critical, community leadership at the planning and decision table, community-led monitoring to be able to validate whether or not what's being promised is actually being delivered, and having that trust with the community to drive interventions forward. We're not seeing that level of participation and access to decision-making tables yet in the COVID response by community. And then I think finally, it took so long in the HIV response, once we finally had, for example, HIV treatment, to make sure treatment wasn't only accessible in wealthy countries. We lost a decade almost, maybe 7 or 8 years before we really started moving access to treatment to the broader world based on need. And not that we're done yet, but we've certainly made a lot of progress together. And I think that is probably why we are so passionate and committed as HIV responders, as UNAIDS, to saying, hey, when it comes to new technologies for COVID, when it comes to a COVID vaccine, we've got to make sure, number one, that production is expanded very quickly, and number two, that allocation is fair, that people who need a vaccine the most get it first, are the first in line, not just based on wealth of the country or wealth of a population in the country. So that's why at UNAIDS, we're part of the People's Vaccine, a call that, a vaccine should be accessible to the people who need it. And we're part of the WHO-led activities to like CTAP to make sure that we can come together as a global community in solidarity to really ramp up discovery, production, and access.
Mm-hmm. And CTAP is a pool for sharing intellectual property for things like a vaccine or a medicine. But you kind of have reminded me of something that maybe struck me a little by surprise. I've seen many of the top HIV groups, including UNAIDS, including AVAC, which is pushing for a vaccine, sending out a lot of messages about the coronavirus response. And on the one hand, it's kind of very impressive solidarity. But on the other hand, I know as a journalist that HIV has kind of struggled in recent years to be in the headlines. And so I've kind of been wondering, well, why are these HIV groups, talking about the same thing everybody else is talking about instead of like really keeping the focus on HIV? Can you just help me understand the thinking a little bit there?
Well, hopefully we can do both, because I think we do really need to be able to put the focus on both. It's not a competition between two pandemics. These are colliding pandemics, and we think we can respond effectively and more effectively if we take into account both. Why are we at the forefront? I have to tell you, when you look around the world, a lot of the lessons that are being applied to COVID and a lot of the infrastructure that is being rapidly mobilized for COVID was built through the HIV response. Across the world, many of the individuals who have been National AIDS Council directors or leading HIV clinicians or public health docs are now leading the national COVID responses. So there's already just a automatic synergy between who we are, how we look at the most vulnerable, and how we respond. And at the same time, I think it gives us a chance to really highlight what's left to do in the HIV response. We mentioned at the top for Europe, and I loved the comments that came before me here, about what's left to do even in Europe. As I mentioned, in Europe, some countries, particularly those in Western Europe, are absolutely going to meet the 2020 targets for the HIV response in terms of treatment coverage targets. You're seeing in Western Europe decreases in new infections. We see that the 15 or 16 countries that are really at the front in Western Europe of their own national response are also making up 50% of the donations to the Global Fund. So they're participating globally. But at the same time, we see different patterns. We see, even in Central and Southern Europe, the epidemic going in the wrong way. We see, unlike Western Europe, where it's not an accident, that the legal framework that protects key population members and LGBTQ members isn't in place or is going in the wrong direction in some countries in Central and Southern Europe. And you see an increase in HIV rates and low successes. As mentioned before, we're very concerned with Eastern Europe, with rising HIV epidemics, and with extremely low treatment coverage rates, even when there have been fairly good diagnosis going around. So it allows us also to remind people what's left to do, because I think a lot of the folks that are still yet to be reached in the HIV response or reached effectively with what they need, they're not being reached in the COVID response either.
Mm-hmm. And we're almost out of time. I want to make sure that we get to our audience question, which you sort of alluded to, I think, in your last remarks. But the question is, how can we combat the rise of populism and its impacts on the HIV response, especially as it impacts key populations, such as people who use drugs and LGBTI people? And that question is from, I apologize in advance, I always mispronounce Irish names, but Shannon Russell from ILGA Europe.
Great. Yes, I think that's a big issue. And let me add one more group to that list, which is migrants. And realizing that sometimes overlapping inequalities really fuel challenges in the HIV response. I tell you, we talk a lot of times about individual level stigma and wanting to reduce that, and we should. We want to get to zero stigma in healthcare providers, by communities, by families. But when we talk a lot of these affected communities, one thing that comes up over and over again is the legal framework, laws, criminalization, protections against criminalization. So to the extent that legal frameworks that we know are evidence-based to reduce the HIV epidemic, legal frameworks that don't penalize people for their HIV status, don't have travel restrictions based on HIV status, don't criminalize exposure or non-disclosure, criminal laws against key population members. The more that we can get protections against those laws in place, then I think individuals are able to participate in their own public health and their own care and their own well-being, even as different challenges and different political challenges wax and wane throughout individual countries. So I think, this year is a new year of target setting that we'll be looking for what should member countries and the UN sign on to for targets for 2025. And for the first time, we're adding some quantitative targets for social enablers, for access to justice, for legal frameworks that are evidence-based to reduce the HIV epidemic. And so I do hope that everybody who is involved in the fight and cares can help mobilize other people to talk to politicians, to talk to their UN representatives and say, you know what, we can pool together and provide some protections that are really going to make a difference for the response.
Thank you, Shannon. We're pretty much out of time. I'm going to ask one last question that will kind of lead us into the next panel. And it's an acknowledgement that the next panel is going to be all men, which is always something that we try to avoid. And it wasn't for a lack of trying on our part. And actually, one of the articles that I wrote for this series is how women are sometimes left behind in the HIV response. Obviously, UNAIDS has a lot of women in top leadership positions, but does the movement kind of at this point have a gender issue?
Always and forever, until we've gotten to true gender equality and parity throughout the world, I think. We can never take our eyes off this prize. And it plays out in different ways. I think certainly different epidemics affect women differently. And, what do we care about? Certainly, issues of gender-based violence and intimate partner violence based on gender identity. These are important elements to reduce if we're going to combat the HIV response. I think sometimes in epidemics that are such as in Western Europe, where it's more men than women, probably one of the biggest risks is that the needs of women living with or at risk for HIV are made more invisible, because they're not just going to be the exact same vulnerabilities or the exact same needs as men. And many of these intersecting aspects of identity, are you a migrant? Are you a sex worker? Are you in a violent relationship? Are you in poverty? All of those interact at a human level in very different ways. So it's just a reminder that even as we respond to some of the bigger gender equality issues and racial equality issues that matter, we also need to make sure the services and the policies we're putting in place don't make anyone invisible, that they're able to bring together what a human being needs to really be empowered to be healthy, have well-being, have a high quality of life, and to be protected with or live healthily with HIV.
All right, Shannon, thank you so much for joining us today. I really appreciate it. We are going to move right on to our panel discussion, and thank you very much to the gentlemen who are joining us. They are Stefan DeWitt, who's the chief of the Department of Infectious Diseases at St. Pierre University Hospital, Patrick Graintons, who's an HIV expert and advocate here in Belgium, Taimur Nuri, who is an expert in HIV and migrant health and has been incredibly helpful to me throughout this Telescope series at the European Center for Disease Prevention and Control, and Nicolae Stefanuta, who's an MEP from Renew Europe and Romania. Thanks to all of you for joining us. I want to go ahead and start with, again, with our poll, with you. What would you say is kind of the top issue that is holding us back from ending the epidemic? And again, those choices were political indifference, drug prices, search for a vaccine and cure, and lack of funding, if I'm not missing any. Stefan, let's start with you. What's your perspective there?
Can you just repeat the question? Because
sure. So we had a poll at the very. Oh yeah, sorry about that. At the very beginning, we had a poll looking at what the top, asking people what the kind of top obstacle to ending the epidemic is.
Yeah. Okay.
And if you could respond kind of from a local perspective, as opposed to feeling like you have to speak about the whole world.
Well, I think the issue is to maintain the HIV/AIDS issue on top of the agenda, and obviously it's difficult in the time being because of we have a totally new agenda and an emergency agenda. So I think that indeed the impact of what we are living now in the COVID-19 issue, whether it will impact negatively or, let's be optimistic, positively on the fight against HIV, remembering us that infectious disease should remain a priority for our societies. And we used to live with the impression that we were not the master of the world and we could manage everything, which just is not true. We are facing a global threat, like we were facing a global threat 40 years ago when HIV/AIDS came out. So I think the major issue now to discuss whether it's a question of money, of policy, of legal, it's a mix of all these things. It's a mix of need for science, etc., etc. So, but I think that the top question is: are we able to maintain HIV/AIDS on top of the agenda?
Thank you, Patrick. What's your take? As a person living with HIV in Belgium, what's the biggest barrier to really ending this epidemic? Patrick, I think we are having a little bit of audio problem, actually. So I'm gonna send that question to Nicolae for now. From your perspective in Romania, what's the biggest obstacle in your country? We cannot quite hear you either, actually. So I'm going to cross my fingers and hope that we can hear Tamar, who can speak about the EU broadly.
Can you hear?
Yeah, do you hear me, Sharon?
Yes, I can hear you. And I did just hear you, Nikolai. So I'll send it back to you as soon as Tamar answers.
Yeah, so in terms of obstacles, I can only agree with Stefan and what Sharon has said beforehand. I think, for me, it's crystal clear that it's about political leadership. Everything else that you had underneath those options about drug pricing, about other aspects, they all end up in terms of political leadership. And I agree with Stefan as well about the competition here of agendas. Having worked with HIV for the past 15 years here at the ECDC, it becomes, it's been obvious for us that HIV should be top on the agenda. But there are so many agendas out there with climate change, with COVID now, with hepatitis, with TB. Everything is a priority for every people who are working in those areas. So it's becoming tougher and tougher to keep this at the top of the political agenda. And we know that there's only so much that can be on the top, right? So we have this constant challenge of keeping HIV on the top of the agenda. So for me, it's quite clear that political leadership in this area is critical, and that's where UNAIDS comes in, pushing and lobbying for these political declarations to mainstream HIV into SDG agenda. Those are so important issues, because without HIV being in the SDG, we would have even less to do with this in terms of resources and political leadership in Europe. So I think this has been absolutely critical.
And Nikolai, we'll try you again. And so in addition to kind of answering my initial question of what your perspective is within the Romanian context, if we could also maybe bring in the point that was just made about HIV on the agenda. Is it your sense? Do you have a sense that it's on the agenda at the European level?
No. Can you hear me now?
We can, good. And I love that direct answer. Thank you.
Yes, I'm sorry. It might sound perhaps less political than you might have expected from the politician on the panel, but it is true. Out of sight, out of mind, it seems to be the case. And I work in the European Parliament on the issue of EU for health, particularly as regards the budget for health of this new program that the European Union came up with. I also worked on the civil protection mechanism, where I fought for stockpiling of certain medicines that are missing around Europe. If I put my Romanian hat, that's one of the main problems: lack of availability of treatments and medicines. So yes, indeed, and I would agree to what Sharon said. If I look at the 1990 targets of UNAIDS, we are not meeting them. We are not meeting them even less in Eastern Europe than in Western Europe. And on top of everything else, there is a problem of political leadership and acknowledgement. But further to that, there is also a problem in communication. And I'm glad that Political Telescope decided to take on this very important topic, because out of sight, out of mind. And it's important now, 40 years onward, to keep it in sight and keep it in mind.
Thank you, and thank you for that direct response, Patrick. Hopefully, we will be able to hear you now. What's your take? Perfect. We can hear you perfectly.
Okay, you can hear me.
Yes.
No, I totally agree. We must see that HIV is still on the agenda. It's like the others already said. It's not always. There are a lot of other things that must become on the agenda, but. For some reason, I think some people think, yes, we have now already enough HIV medication, and the crisis is not going on. And that's something that it's not correct, because there is still a lot of work doing worldwide about HIV/AIDS.
Mm-hmm. And let me stick with you. You were first diagnosed in the 1980s. We've come quite far in terms of treatment. What are kind of the biggest changes that you've seen since then? And also kind of on the other side, are there things that have not changed over the decades that you're feeling kind of frustrated about.
Yes, I know now for 35 years that I'm HIV positive, and I think, yes, the biggest thing what is change is that in the beginning, yes, you get the diagnosis, and the doctor, they say to you, yes, you must prepare because you will die of the disease. And now we see people living with HIV, they live with a chronic disease, and that's the most important thing, that there is a lot of future for people, that they have a future to live with HIV. Important is still, of course, the stigma that there is for a lot of people living with HIV, and not stigma in their with family or friends, but sometimes in the care where you go. If you don't go to your HIV clinic, but you go for another problem with your health in another with another doctor, that there is still a lack of information. People don't know the USU message, and yes, we must invest there.
Mhm. And Stefan, same question to you from a medical and public health response. What are the most important changes since the 80s, early 90s, and where are you frustrated that there hasn't been more progress, or where you think should be the next kind of real push? We are having some audio issues.
No, sorry.
Okay,
it's
there
me.
we are.
I'm back. So obviously the main progress has been in the field of treatment. We moved from no treatment to very inefficient treatment to effective treatment, but very difficult to take, to more simple treatment which are now available. And this progress is still going on. We will get now treatment with less drugs, maybe with less intakes. We will get treatment with injections every month or every 2 months or even more. So clearly the field of treatment has been a major progress, and has been a major contribution also to prevention, because when you are treated, as we all know, you equal you, so you are not a transmitter anymore. Now, the new fields which appeared is clearly the aging issue of HIV population and the need for taking the individual globally. It's not just a patient with a virus, it's a patient with a virus, but also with the consequences and the long-term consequences of the virus, of what happens on the immune system, and potentially of the drugs, and at least of some of the drugs, and hopefully the new drug will not lead to this. So it's really taking all these individuals globally, certainly on the medical point of view, but of course also on a psychological, social, sexual issues, etc., etc. What is still frustrating for me, and it comes back to what Patrick said, is the lack of consciousness of the non-HIV medical community, I would say, about this issue, which has two consequences. The consequences on the HIV patients, as Patrick mentioned, stigma, rejection, lack of competence, lack of access to certain care, etc. But also, and this plays a major role, missed opportunities. We are still seeing too many cases, too many patients who have meet a lot of medical structure, which could have been involved in testing, because all the signs, all the symptoms, all the context were there to propose an HIV test, and this is not proposed for years and years. So for me, it's one of the major reasons for the high proportion of late presenters that we still see. In my saying, it's 38%, and globally in Europe, it's above 40%. It's close to 50%. This is totally unacceptable. So there is here a major effort to pursue on medical education, also of education of the communities, which could somewhat help the doctors to improve diagnosis process. So this is one of the major frustration. I think we are still living every day with new diagnosis. And then, if I may, another aspect that I would like also to highlight is availability of PrEP to other population. In most of the countries which are using PrEP, it's mainly in MSM, which is of course absolutely adequate. But we need now to move to access to PrEP, which is a major preventive tool in other populations. So these are the plus and the minus points from my side.
And as far as PrEP access, is it your perception that it's a price issue, a sort of an infrastructure issue? What's the barrier there?
It's certainly a complicated issue, because if it was simple, we would have found the solution. So it's certainly access to the population which could need PrEP beside the MSM population. And so the first is to identify this population, to identify their way, how they will meet HIV, and try to act during that process in these specific population. And certainly women are totally out of the PrEP field today, and especially migrant women, which are a high risk group in many countries. And we know that we should not think that they all come to Europe after being infected. A lot of these women become infected in Europe. So we have something to do, and this remains for me a very frustrating issue, but it's a difficult one, and I think this needs research, involvement of communities, political will, good communication, etc., etc. It's a difficult task, but it's one of the improvement that we should implement in terms of prevention in Europe.
Thank you. And thank you for making those points. We, if people who are watching, if you have not been following our Telescope series, we've written actually some full articles about some of the issues that have been brought up, such as migrants, women. Our last article was about the struggle for HIV positive patients getting other types of medical care. So lots there. And just a little bit of choreography. Nikolai, I will ask you in a few minutes to respond to some of the points that Stefan just made. But before we do that, Tamer, if you could just sort of give us a little bit of the lay of the land. We've heard from many people about the inequalities in Eastern Europe and Western Europe. And can you just kind of help us get a grip on what those look like, please?
Yeah. So let me put it in the perspective of the SDGs. So we have these targets on the 1990, which you've heard about, and their target of a 75% reduction in HIV incidence that needs to be achieved in our region. And when we look at the division, the inequalities in our region, it's huge. So in Western Europe, as we've heard, we are starting to see a decline in HIV incidence. We're nowhere near the 75% target. We're seeing a 13% reduction over the past decade. We should have seen a 75% reduction. So we're even in the western parts of the region, we're not there yet. We're starting to see declines among MSM, which is really positive. But the huge increase is happening in the eastern parts of the region, and this is where we obviously are lacking. It's the same when it comes to the 1990. We're seeing more and more countries now achieving this target in the western parts of the region, where we have pretty much reached these targets, I say, as a European Union as a whole. But even within the EU, there's huge discrepancies where the big countries are on track, but the smaller countries in Central and Eastern Europe are still far away from reaching this target. And outside of the EU, in the eastern parts of the region, we see only 25% of people who are living with HIV who are reaching viral suppression. So we're still very far away. And I just want to say, in terms of that we don't get stuck on these 90, what we're seeing, even countries which are achieving these targets, many of these countries are not seeing a reduction in incidence. And as Stefan said, most of these countries are still seeing late diagnosis of above 50%. And we know if you are diagnosed late, you are much more likely to die and suffer consequences of this. So I'm a bit concerned that politicians and people not working in this field think that we're doing okay and therefore that it needs to drop off the agenda. And I think that's what's happening. And that's what a communication error that we have here. We're still seeing a significant proportion, 200,000 people in Western Europe who are living with who are not virally suppressed, which means they're able to transmit the virus. So in terms of the priority in our region, we really have to focus on prevention trying to test people and put them on treatment as soon as possible. And if I may, I just want to mention one more group in the western parts of the region which has received little attention, and it's this issue of migration. So we started to see a decline among MSM, which is really promising. But when it comes to migrants, we have seen a decline, but that's not because we're seeing prevention efforts towards migrants. It's the influx of migrants to Europe has changed. So we're seeing fewer migrants from high endemic countries, and therefore we're seeing a decline in our region. But what's really critically important in our region is that this issue of post-migration HIV acquisition. So once migrants come to Europe, they are HIV negative, but once they live here, they become infected because they don't have access to prevention, testing, and treatment. And this number is really, really high in many Western European countries, and this is a top priority that has received very little attention. So I'll stop there.
Thank you. And just quickly, can you remind us what the 90-90-90 goals are and mean?
To see is 90% of all people living with HIV needs to be diagnosed. Once you're diagnosed, 90% of those need to be on treatment. And once you're on treatment, 90% of those people should be reaching viral suppression. If you reach these 90-90-90, 73% of the population living with HIV should be virally suppressed. And according to UNAIDS modeling, they are saying that if this goal is reached by 2020, we are on track to meet the 2030 goals. Now, there is evidence coming out that this may not be enough, this 73%. To really see a significant reduction among MSM, for example, studies are coming out to showing that we need to see a 90% reduction, 90% of people virally suppressed to really see a significant reduction. So even though we're starting to feel that we are on track towards these 90-90-90, we may not actually be able to reduce, to reach these targets by 2030. So we have to be much more ambitious going forward.
Mm-hmm. Mm-hmm. Thank you, Tamer. And Nikolai, Stefan outlined kind of a lot of different issues where one could imagine maybe some EU level engagement, such as training of medical professionals to be kind of more aware, medical professionals who don't always deal directly with HIV to be more aware of how to deal with that. He also talked about some access issues, such as PrEP. First, what's your sense of how things like PrEP rollout are going in Romania, and where would you like to see the European Union engage more in general? And I'll also interrupt myself here. We have several great questions coming in, and I just want to encourage everybody to keep on sending those in, and I'll get to audience questions in just a minute. So please go ahead, Nikolai. Thank you. I think, if you're muted, yeah, I think your mic is muted. And I know that we all say that it's good Zoom etiquette to mute yourself when you're not talking, but please consider yourself released from that good Zoom etiquette during this session.
I have unmuted myself.
Perfect. We can hear you now. Thank you.
Yes.
You're good.
So I do believe that the public has an expectation that the EU steps in where the nation state fails. It happens in every other political sector, and they don't understand why it wouldn't happen in the field of health. In particular, in my country of Romania, I have a few statements by Ana Maria Schweitzer, who's the executive director of Baylor Black Sea Foundation, and Mr. Petre Iulian, who's from the National Organization for Persons Affected with HIV. And they all say that the problem is, first of all, scarcity. There's lots of treatment. Antiretroviral treatment is missing. There's shortages. The other thing is PrEP, pre-exposure prophylaxis, is currently unavailable in Romania. Furthermore, 56% of HIV patients living in Romania do not know their viral load. So that means, your rule that undetectable means untransferable, it's actually losing its significance in that context. And on top of it else, COVID-19 has made things more difficult because there's a problem with connecting and attending doctor's visits. Romania is not high on the digital agenda. Some of the prescriptions that can be done via electronic means is basically unsupported by the national insurance system, so it's not available. And last of all, but not least important, because for the political class, this is an issue that is out of mind, and because it's an issue that touches on vulnerable social groups like migrants, like LGBT communities, like sex workers predominantly, they do not see it as an obligation to deal with it quickly. I know that it's a harsh reality, it's a very brutal reality, but I'm also a member of Renew for Equality, which is a group advertising for rights of minorities. And, first of all, I think I'm the first Romanian member to be ever part of that group, which is kind of crazy, but it is like it is. And we need to move into modernity and not forget that this issue is also political and also cultural, unfortunately. And we need to move culture in the right direction, move politics in the right direction.
Thank you for that that blunt response. I'm gonna ask kind of on a similar theme. I'm gonna ask a question that we have from Dario, and that question is talking about HIV and STD stigma. Many countries still discriminate against homosexuals when it comes to blood donation, and Dario wants to know people's reaction to that. So, Patrick, is that an issue that you've been monitoring? Oh, Patrick, we can't quite hear you.
Mute myself.
There you go. Again, feel free to just keep yourself unmuted throughout.
I didn't unmute myself.
Okay,
No.
Thank you for fixing it.
About the blood transfusions, we in Belgium, of course, there is also restrictions. You have to, if you are a gay man, you have to wait. You then don't have for 1 year sex, and then you can donate your blood. And we, I also worked for an HIV organizations, and what we think it's important that with all the new information we had, that you must see, is it still need that homosexual men can give their blood? But it's a tough issue. It's also about health, and you must think very good about it if you if the restrictions are going change or not. And you must see it country by country, because like already said, not in every country there are enough tested people can have the HIV medication. So it's not a easy issue, I think.
Mm-hmm. Mm-hmm. Stefan, what's your perspective there? Is there sort of a medical justification for some of these rules? I mean, just not having sex for a year sounds like kind of a bummer. Just to get blood.
This is a little bit crazy, It's and I would like to know who will control that. Maybe we have to invent some IT system to control whether you have sex or not. So this will be a funny era. It's a difficult question. It's a difficult issue. And I can fully understand that this could be perceived as a stigma. But on the other hand, it's also a public health issue. So in a community where the virus spread remains significant, and where a lot of transmission occurs from people who have been recently infected, so which are the ones where diagnosis could be more difficult and prevention of transmission by blood transfusion could be more difficult. From a medical perspective, it's an important issue, and we should not just deal with that issue just on the point of view of stigma, but also on the point of view of public health. So a compromise is very difficult to find, and saying, okay, no sex for 1 year, is a little bit hypocritical. And so personally, I don't think I perfectly understand the issue of stigma, but honestly, there are other much more urgent priorities, and I would much more prefer that we put our effort on improving diagnosis or other issues. So let's keep seeing at the right place, I would say. Just that.
And another audience question that is also looking at kind of how to deal with public health and interaction with prevention and stigma messaging. It's from Christiana Nusslinger, and she asks, changing the PrEP marketing from risk reduction tool to health promotion tool, would that help reach key populations? Tamer, is this the type of thing that the ECDC potentially could engage with, especially given your knowledge of the key populations involved here?
Well, to be frank, I'm not really sure I understand the question. From a risk reduction to risk marketing.
Sorry, risk reduction tool to a health promotion tool.
To a health promotion tool. Yeah, well, I'm still not really sure what that means, to be honest. For me, it's the biggest problem for me when it comes to PrEP is several. One of the questions you asked before is pricing. Is that the big problem? I think that has been a huge stumbling block, but prices are coming down now. So for me, it's a lot about demand creation, and maybe this is what health promotion is. So demand creation. There's a lot of, as Stefan said, the most people that do get PrEP, way too little people do get PrEP, and we've estimated that gap to be around 500,000 in the EU alone. And as Stefan said, most of the people that are getting access to PrEP are men who have sex with men, and we see huge gaps for other populations. So and I don't see them. I see the issue. Maybe this is where the health promotion comes in. I think a lot of migrants, a lot of people inject drugs, a lot of cisgenders, etc., transgenders, etc. Maybe they don't know what PrEP is, and we've seen this lack of awareness, especially in the eastern parts of the region. They're not really sure what PrEP is even. EMIS, with a huge study, behavioral study done in our region, showed that a significant proportion of people, of men who have sex with men, didn't even know what PrEP was. So if you don't even know what PrEP is, how can you even demand to get PrEP and know the benefits of it? So this is maybe where the promotion comes in. So I think there's a huge demand, a huge need for promoting PrEP in our region. I'm not sure I answered the question correctly, but I'm sorry.
I think you answered it very well. And Nikolai has to leave in just a second, so if I can just hold on to him for okay, he's okay. If I can definitely, in any case, ask you, Nikolai. He's not there. Okay, sorry. I was going to ask him a bit about the EU for health budget because he is the rapporteur. But basically, if anybody has strong feelings about the bloc's the actual money being put towards a health union, then he is the man to get in touch with in the European Parliament. But for now, I will go on to another audience question. I urge you to keep sending things in. It's another one from Christiana, and she is reminding us that we cannot just keep this perspective on Europe, even though that's what we tend to focus on here at Politico. But actually, it remains sub-Saharan Africa. That's one of the most affected parts of the world. So her question is, what can be done to especially protect girls and young women in sub-Saharan Africa who are the most vulnerable and have worse treatment outcomes than adults once they're HIV positive? So Stefan, is that one that you are able to weigh in on here?
Well, I'm not a specialist of the situation of Africa. I must say that I see Africa through our European eyes and what we see here. So obviously the issue in Africa remains huge, and if we have to compare with our countries, we are in another universe. So there have been major progress in some of the countries, but many countries remain far from the objective for many different reasons, mainly, of course, political and economical, lack of structure, lack of access to care, etc. Now, among in terms of prevention so I think that once again education is a major tool. Education of the communities, education of the medical communities, to try to build models which could help and implement new ways of prevention. And once again, it will be a combination of many different preventive tools, and really the medical prevention will play a major role. We know that circumcision plays a role. We know that virucide could play a role, and then we have treatment as prevention. And hopefully one day PrEP, but I think that in Africa we are very far from being in a position to implement PrEP. So it's really a combination of many different tools, and probably one of the priorities care, and by caring and putting more people in undetectable situations, this could have a major impact on transmission. And for me, that should remain the priority both for the individuals and for the African societies.
Mm-hmm. Tamer, one of the things that's on the political agenda in Brussels right now is expanding the resources and potentially the authority of the ECDC. That conversation has been happening in the context of the coronavirus, and the sense that European countries didn't act in a concerted way to respond. But are there ways that you could foresee more resources or more authority for your organization, for your agency, helping improve the HIV response on the continent?
Well, it's interesting. I think that debate is happening right now. And I just heard earlier this week that discussions are happening to change ECDC's mandate in light of what's going on in COVID, and that this may be discussed in the next EBSCO Council, which is happening later this month or next, I believe, where they're discussing ECDC's mandate and probably increasing the budget. And it's... I think I haven't been privy to those discussions. I think it's still very hush-hush, so it hasn't trickled down to us. But I do think it comes in light of, as what you said, that the responses have been so different in Europe. And we're getting questions from the European Commission and member states on a daily basis now on everything to do with COVID and responding to COVID. And what's becoming crystal clear is that there's no coordinated response. And I think it was Shannon who said in the beginning that in terms of portfolios in the European Commission, health is very weak. It's very much in the mandate of member states, and that's the way they wanted it. And maybe they're shifting now towards this. So there are discussions about expanding our mandate to also step into monitoring of health systems, which has definitely been outside of our mandate, and trying to monitor health system capacity and preparedness. And that's what I've been hearing. And in terms of budget, I don't really know what that means for budget. I think it's more about the mandate. Do we have a mandate to step in here and try to coordinate the response? Currently, it's very weak, and I think that's what the Commission are discussing right now.
And as an employee of the ECDC, is that exciting to you? Or are you like don't make me have to deal with that?
No, it's very exciting. It's very exciting. To be honest, 10 years ago, before the financial crisis hit, there was also discussions about expanding our mandate to non-communicable diseases, because that's where the real disease burden is in the EU. And there is no center for Europe around this issue. It's coordinated from the Commission through various networks. And, that I don't hear that anymore, which is fine, because of the financial crisis hit, and that was just out of the question. It's too costly. But I haven't heard that for this perspective. But yes, it's very exciting because it is adding more weight to the issues that we really care about, which is health and public health, and that has up until COVID been diminishing in importance within the EU. I felt, and this is could be something positive coming out of it. Yeah.
Mm-hmm. And Tamer, thank you for mentioning non-communicable diseases. Patrick, I wanna talk to you a little bit about something that you mentioned when we were preparing for this panel, and that is that one of the new challenges facing people who are doing very well on treatment are mental health issues. And can you just shed some light on what people living with HIV are you just facing the exact same mental health issues that kind of everybody else is dealing with, especially in this COVID time, or are there some unique challenges that we need to see, medical professionals getting more training and dealing with?
Yes, what I saw and what we hear and what you also saw in surveys is that the mental health issue is a bigger problem for people living with HIV. It's also because of the stigma that they feel, because that they don't because there is a lot of changings. It's all about a medical issue, but indeed people want to talk about their HIV status with others. And you see in a lot of HIV centers, there are more doctors now, and that's important. But I think it's also good that there is a place for more HIV nurses who are specialized in some things, that there's also a good connection with the community organizations, that they can give peer-to-peer support. Also, because yes, you see a lot of people who are suffering from a lot of things, and also they have now a long life with HIV, but it's important that you also give them a long good life and with HIV, that they also can make plans and can have love and happiness in that life, I think. And not only, yes, you live longer because there is medication.
Mm-hmm. Well, thank you for that. And I think I'm going to go ahead and wrap it up here. So thanks so much to our panelists. Let me just kind of take a look back at some of the key points that stood out to me over the course of these discussions. We are definitely facing a competition of agendas, and HIV was struggling to be on the political radar even before the coronavirus. And it is remarkable, actually, if we think of what a searing issue it was over the decades. And that's an area where maybe HIV has actually, the movement has been a victim of its own success as far as the progress of medical treatment. But as we pointed out, we're not meeting our goals to achieve the end of the epidemic as we hope to do by 2030. There's vast inequality across the block, especially on things like access to PrEP. Stigma remains a challenge throughout, whether it's things like people struggling to get non-HIV medical treatment, or the sort of challenge of figuring out how to allow things like blood donation. And then the other issue is, as people are living longer, we're still trying to figure out the long-term effects of both the medications and the impact on mental health, as Patrick just mentioned. But at the same time, I was pleasantly surprised to hear this optimistic note, even though many HIV specialists have sort of been pulled away to focus on the search for a coronavirus vaccine, even though there's been some threat to people getting access to their medicines because of lockdowns. I heard from especially Shannon and Stefan a note of optimism that this recognition that we need to deal more with infectious diseases and that we need to be more united at the European level on health issues. Those could actually be areas where the coronavirus pandemic actually ends up helping fight HIV in the long run. So with that, I will wrap everything up. Thanks again to all of our speakers, especially since we made you wait a little bit. Same thing hugely to our audience. Thanks so much for your patience. Thanks so much for your engagement. Thank you to our partner Gilead for making this event possible. So please do send your feedback in to events@politico.eu. We'll also be hosting other virtual events this week. You can check out our website for event updates. That's politico.eu/events/future events. Thank you so much for joining us.